Menon, Rahul, Radhakrishnan for a controversial topic. Do we really need to panic post-op, end-off or sterile inflammation?
So, a very warm good morning to everyone. I would like to thank Dr. Divya for this opportunity. So, I'll be talking about post-op endophthalmitis versus sterile inflammation. So, do we really need to panic? This is a pretty rhetorical question actually for any ophthalmic surgeon. You see a inflammation in your post-op patient, you are going to, depending on your level of expertise, you're going to panic to a certain extent. So I'll be talking about three case scenarios. So you see your post-op day one patient complaining with redness pain. He or she has an AC reaction, fibrin plus minus with a hypopion, and the posterior segment is quiet. This is the first case. The second case is a post-op day 5 patient with redness pain, AC reaction, fibrin, hypopion, and the media is, the fundus cannot be visualized very clearly. And the third case is you had operated almost a month back. The patient comes with pain and redness. You have reaction, hypopion, and the media, there's some amount of haze. So, any inflammation within the of the eye, either in the anterior segment or the posterior segment, is called as endophthalmitis. This could be either infectious or sterile. So, infectious endophthalmitis could be exogenous when it happens following a trauma or intraocular surgery, or it could be endogenous when it spreads into the eye from a distant source. And the non-infectious causes include when it happens following when the liquefied matter, lens matter, goes into the vitreous cavity, especially after hypermature cataract surgery, or it could be because of intraocular tumor necrosis, post-trauma, or post-phacoanaphylactic. So the first main cause for sterile inflammation is TAS, that is toxic anterior segment syndrome. So this can happen following cataract surgery, keratoplasty, and even after posterior segment surgeries. So basically, there's an unusual anterior chamber inflammation in the early post-operative period. So what really happens here is the non-infectious substance enter the AC and they cause toxic cellular and extracellular damage. Now, it could be acute, which can happen within days, or it could be delayed. It usually starts a little earlier than endophthalmitis, infectious endophthalmitis, and you will have usually see limbus to limbus corneal edema. Pain is usually very minimal, even if it's present, and the anterior hyaloid is usually quiet. So, if you look at for the AVF cells, you usually should be quiet, but if there's severe reaction, sometimes there might be a spillover reaction. So, but one thing you should all know, because what we tend to diagnose is on the onset of symptoms. So if you just see, in the early period, we might diagnose it as TAS. TAS can even happen little later, as it can come as a delayed presentation. So Miyake and group have reported cases of late onset TAS, which have occurred after about 42 to 137 days post-surgery. And to look for a cause is very difficult because Sengupta and group have reported from Arvind's study, what they found was like no etiology could be found in about 52% of the cases. So the ASCRS task force suggested that improper cleaning of the surgical instrument is the most common cause of TAS. So it could happen following a surgical instrument contamination because many times we use ETO sterilization of the surgical tubing that we use, or sometimes inadequate flushing of the handpieces can actually cause TAS. Even if we stay in the capsule of following cataract during cataract surgery, if we stay in the capsule for a longer time, or even the various drugs that we use, if they contain preservative or inadvertent dilution can also cause TAS in the post-operative period. And sometimes the patient's clinical characteristic, especially diabetics, they tend to have severe inflammation post-surgery. So the treatment is, if you see a mild TAS, the treatment is with topical steroids. Moderate to severe, you can give subconjunctival dexamethasone. Severe cases, you might have to start them on oral steroids. Sometimes you will see fibrin in such cases, which is refractory to any treatment. So in such cases, you can actually use intracameral injection of RTPA. If the inflammation is not subsiding with treatment, do not hasten, think it is and treat it as endophthalmitis. Sometimes you can also develop these patients of TAS can have CME. So in such cases, you'll have to treat it with intraocular steroids or anti-VEGF. Now, endophthalmitis usually presents with defective vision post-surgery, lead edema, chemosis, hypopion, AC reaction, vitreous inflammation, exudates, and retinal hemorrhages. Now, if you're talking about one investigation which always saves our skin is B scan. So whenever in doubt, even if it's a TAS or no, or it's an endophthalmitis, get a B scan. because you have the other eye as a reference. So look at the vitreous opacities. If you see there are compared to the other eye, if you see more opacities, vitreous opacities in the affected eye, take it as endophthalmitis. You will see a retinochoroidal complex thickening, and also look for choroidal detachment and retinal detachment, because it helps us to plan our management. Then once you suspect endophthalmitis, the treatment is you have to take a AC tap, or we can take a vitreous tap, which I'm not very happy suggest a vitreous tap, because what happens is inadvertently we create a traction on the retina and we actually cause much more complications. Vitrectomy, if you really want to take a vitreous tap, go think of vitrectomy, because it has a higher diagnostic yield for culture when compared to vitreous tap. Because many times when you take a vitreous tap, it might be dry tap. Now, once you get the sample, send it for microscopy and culture. Along with that, get a PCR done, because PCR has an increased sensitivity compared to culture. Second most important thing is rapid diagnosis. So if you send the sample for a U bacteria or a pan-fungal genome, you can get the report within 90 minutes, whether you're actually dealing with the case of endophthalmitis. The only limitation being that you cannot determine what antibiotic you have to use in such cases. So intraocular antibiotics, if you are suspecting of bacterial endophthalmitis, for the gram-positive spectrum, you treat it with vancomycin. For the gram-negative, you can give ceftazidime or imipenem. Even nowadays, we use a lot of piptas, which covers both, and because if you see in the multispecialty model, nobody starts with simple antibiotics. They all go for piptas and stuff like that. So piperacillin tazobactam which is one antibiotic which covers both the gram-positive, gram-negative, and as well as anaerobic organisms. In bacterial, you have to treat it with dexamethasone also, along with the intraocular antibiotics. Also, oral steroid has a huge role in exogenous endophthalmitis. The reason being, the damage that is being done is not just the infection, but also the ongoing inflammation. So you have to take care of that also. So oral steroids, definitely you have to start in a case of bacterial exogenous endophthalmitis. If you're suspecting fungal, you have to treat it with the anti-fungals that we prefer is voriconazole or amphotericin. The treatment is very simple. You can either go for tap and inject, or you can treat it with vitrectomy with intraocular antibiotics, or which plus or minus oil. The treatment has, from a VR perspective, tap and inject is something which we don't prefer nowadays. We see suspect an endophthalmitis, time is the most important crucial thing that you have, because any delay in diagnosis, many times you see it, I would prefer to go inside and do a plain job, do a vitrectomy. That is what we prefer now, unless there is very few cases where we are still dicey whether it's inflammation or it's an endophthalmitis. Might try give a trial of one dose of tap and injection. But if the second it's not subsiding with first injection of antibiotics, prefer to go in. So the three cases that I was discussing about, the first case, I would take it as TAS. Okay, what I'll usually treat it with, I'll increase the topical steroids, start them on a cycloplegic, probably even if there's severe inflammation, I might also give an intravenous steroid, and keep a very close watch. Very close watch means I would not mind calling the patient the very next day or even the day after. And if I feel that the inflammation is not subsiding, I'll treat it as, I will prefer to err on the side of over-treatment and treat it as endophthalmitis. The second case, it definitely looks like an endophthalmitis, either tap and inject or directly go for a vitrectomy and clean the job. The third case is, many times once the patient stops the topical steroids, they might come with rebound uveitis. So restart the topical steroids with the cycloplegic. If there is any history suggested that the patient might be has a history of uveitis, start oral, you do a uveitic workup. But again, in such cases, because you have to keep the element of delayed endophthalmitis also in your mind. So if with the close watch, if you feel that probably it's not improving with treatment, take it as infective and treat it as endophthalmitis. So to just summarize, to diagnose endophthalmitis or stellar inflammation solely on the basis of onset of symptoms is very unreliable. That is something which most of us do. Pain may not be the only symptom. It might not present on all cases of endophthalmitis. And in any ambiguous situation, prefer to err on the side of over-treatment and treat it as endophthalmitis. Thank you.
Thank you, Rahul. I have a question for you, Rahul. Have your management of endophthalmitis changed in the recent past? Like, have you changed that SEPTA Vanco to PIPTAS?
I have started. I see when we were in during our fellowship days, it was like you see a case of end off, take the tab, AC tab, started with injection. But now I prefer, if I suspect endophthalmitis, I would prefer to go in directly, start with vitrectomy. I don't wait for they take one tab, send it for culture. It might take another 3 days, 4 days to get the report, and then because time is something I feel is the most crucial factor. So one thing that, and vancosefta, if it is, I feel it's not a doubtful cases where I'm taking an AC tab, I might try treat it with vancosefta and deca. But otherwise, I have tried piptas, and even for gram negative, rather than ceftazidime, I'm preferring imipenem more nowadays.
Okay, even without a single dose of injection, you are directly going for that
Yes.
early vitrectomy.
Yes.
What is your take on that, DB ma'am?
See, like as Dr. Rahul mentioned, in case the endophthalmitis is severe, like in very suspicious cases, whether it is an inflammation or an infective cause, then only I would go just with an injection. Otherwise, vitrectomy and then send the sample, then give antibiotic.
Because I also think early vitrectomy does a lot better for the patient.
Definitely, because I have had a few cases where referred endophthalmitis to me, where they had taken the tab, they had injected with some antibiotics, gave to me after 7 days, went in, did a good clean job. But what happens is all the inflammation and like I said, the patient was not started on oral steroids and everything, post inflammation, everything. What happens is finally, by the time you go in, many times you won't even be able to do good justice to the job. So one more thing, what I would prefer is, I don't know how everybody has their own this thing. Uh, it's not just about doing a co-vitrectomy. I
Yes,
try to induce
exactly.
a PVD, and probably I might do a clean job. I'm not worried about creating a break. If I create a break, I'll do a laser. I know how to settle the retina, put oil and come. Not an issue. But I would prefer to do a clean job.
Yeah.
Every person has a different take on that. I don't know
No,
what
I
DB ma'am would
completely
say.
agree with that. That instead of core vitrectomy, if you do that and PVD induction and do a clean vitrectomy,
But
that do
there are certain cases I have
yeah.
burned my hands too. Many times, if I see the retina is very inflamed, I might not induce a complete PVD. I will just induce it, tease it, and then come back. So that probably, I think Dr. Divya might have more experience in that.
No, I mean, like I would also go for a near complete, but I wouldn't like to make any breaks actually, because endophthalmitis and breaks, like many a times the case we lose actually. So, but one of the causes for a late actually failure of the case is many of the times in the pars plana region, especially when we do it in cases where we do a lens sparing vitrectomy, like endogenous or something like that, where you preserve the vitreous in the periphery, where you can't go exactly in the pars plana region or the vitreous base actually. So there it contracts after some time, it causes detachment of the ciliary body, it
Phthisis.
forms a cyclitic membrane, and many times we lose this case because eventually the patient goes for hypotony and then eye goes into phthisis. So when you talk about these near total complete vitrectomy, these vitreous based dissection actually is very important. That's what.
Like I
But
said, I do look at the case. If I feel the retina is very inflamed, I won't induce a PVD and do a complete vitrectomy, but I will just induce and tease it PVD, and then kind of probably inject again after a couple of days. But otherwise, if I feel the retina is not that inflamed, depending on case to case, I'm like,
I will always be very careful. I mean, like if I create a break, then I am.
And one more thing, ma'am. What about the silicone oil insertion after this vitrectomy? Any indication for that?
See, in some cases where you feel like, okay, I mean, there are various studies which have shown that silicone oil injection at the end of the endophthalmitis has got a role, both like an anti-infective, and in case if it buys you some time to re-intervene. Suppose if you have created a break in the periphery and you have missed it, then it gives us some time for a second intervention. Otherwise, we will lose that eye because it may rapidly progress for a closed funnel RD.
and the oil also has a bacteriostatic action, so
Back.
it is preventive, helpful in that condition state.
Thank you, Rahul. So thank you one and all. So we will wind up this session.